Good evening. So I think in the interest of time, because we don't want to interrupt people's dining plans this evening, we'll start this session, which I'm grateful to Boston Scientific to put this on for us and for asking me to chair. I've got a fantastic two speakers and panel with me, Valeria and Nicolas. So this is going to be a really good session. And I don't know how I'll get my slides up, but I've only got a few slides to show. So, it didn't start with the first one, unfortunately, but PCI seems like a very simple thing to do. We have all the tools to understand what we're seeing, we have all the tools of preparation, and of course we have how to finish with stents or DCB we've heard so much about. But of course there's many complications that can happen in that process. Now, intracoronary imaging is the one tool that we have that definitely can eliminate some of those complications in terms of preparation. And we have very good data. This is our BCIS national database. IVUS is better than angiographic. And even in very complex operators who do more cases, it gives you more benefit and potentially adds extra to those cases, reducing event rate. And indeed, when you look at operators in different quartiles, the more cases people do, the better they are at doing these cases. So experience is really important, and it's changed our recent guideline about how to do PCI in the UK. So experience is everything. We start off when we're learning, we train with people, we get good at something, but sometimes we won't always do that frequently enough. And that's where we need to be buddying up with cases and working with high volume operators. But education's key, and that's where companies like Boston have added so much here. Left Main Academy, bench models, courses, workshops, lectures. It's all there for us. It's all very easy. And we are the teachers in this room to teach our next generation. So putting all these pieces together in a jigsaw is really important. Now, what we're going to hear today is from two high-volume operators. First from Valeria about imaging and what imaging can add to the mix. And then we'll hear from Nicolas about how to really prepare vessels and anticipate problems. And that's really the key. So the whole point of this session is not to teach you, because you the room know how to do all these things. It's really just to make us in a situation where we can empower ourselves to teach others and to bring the bar up across the field for patients with left main, particularly treatment. So without further ado, I'm going to hand over to Valeria, who's going to give us our first talk.
Thanks, Peter, and good evening, everyone. Can I have my slides? Indeed, as Peter suggested, we are not here to teach, but to discuss together, to talk together about how intravascular imaging can help us, not only in guiding the procedure, planning the procedure, but also recognizing some potential source for mistake and potential catastrophes in the cath lab. So this is an algorithm, you know, it's a 1, 2, 3, it's equivalent as see, treat, and prep. But I want to focus your attention on some specific additional thing we want to add in the setting of bifurcation. We want to use intravascular imaging also to assess wire position, side branch assessment, and also to check for complication, stent deformation. So let's start from basics, and you know that the intravascular imaging can help us in identifying the lesion severity and resolve some misleading angiographic imaging, some ambiguity at angiography. So for example, in the first row you see that it looks like an isolated lesion of osteo-LED, but when we look at intravascular imaging at IVUS, we see that the lesion is running towards the left main. It definitely includes also the polygon of confluence. And when we look at the third and the second and the third row, we see that at angiography, we cannot really deem if this lesion is severe enough to be treated, but then at intravascular imaging, we clearly clarify indeed what's going on. And after lesion severity, of course, we want to assess lesion morphology, and also check whether we have used the right technique and we have achieved a good result in a lesion preparation. So you see here a very calcified lesion that was a left main LAD lesion, and you see that after the bulking technique, after using specialty balloons, we clearly identify some fractures at intravascular imaging. So we know that we have done a good preparation of the lesion. And this is an interesting case. You see that there's an arrow pointing at a distal LAD. At angiography, you might say, I mean, this is a calcific lesion because that was just right before any pre-dilatation, any intervention. Then after pre-dilatation, you see again this radio opacity. So the question is, what's going on? Is still the calcification I saw at the beginning, or is something else going on? It's contrast staining and dissection. Well, we need to know that, because when we select the stent length, we need to know where to land, and that what we can clarify with IVUS. You see clearly that there was not only a calcific lesion, but that level there was also a dissection. This was a really complicated case of a patient coming in with a cardiogenic shock after left main LAD stenting, and then I wired a CX. But you see clearly that I was really happy in the false lumen. So luckily enough, I advanced a catheter, an IVUS catheter, and you can see the whole 3 layers of the vessel pointing towards the external part. So I was absolutely in the false lumen. And also after crossover stenting at intravascular imaging, we can identify if there has been a plaque shift toward the side branch. And particularly a longitudinal view, we can see if there, instead of a plaque shift, there was a carina shift. So basically, we overstretched the main vessel, and in that case, I mean, the carina was shifted towards the side branch. Apposition and expansion. I know some people in this room will fall after from their chairs after this lesion, which was after this procedure sent from another center. You see that they try to nail the ostium, and when we look at the angiographic final result, it looks okay. But the patient came in 1 year later, and I had to deal with it. You see there's some haziness at the bifurcation. What's going on there? Well, IVUS clearly identify underexpansion and malapposition, because of course the stent was not sized, was not potted, was not post-dilated. So I mean, it was clearly some a condition which we can predispose to stent failure, and that I had to solve with DK culotte with a nice result at IVUS. And this is a complex case of a calcified lesion, and that you see that at the level of polygon of conflicts, there's something going on that's extra layered, there's too much metal there. What's going on? Well, we can recognize what's going on with intravascular imaging. In this case, too much calcium, the catheter interacted with the stent previously implanted, nicely implanted in the left main towards the LAD, but the collision actually provoked an unintended stent deformation. You see the double layers of the stent at IVUS. And this is an algorithm how we can integrate the intravascular imaging in assessing baseline complexity of left main bifurcation, and also after crossover stenting, in order to decide whether to proceed to 1 stent or 2 stents up front. Thank you.
That's fantastic. Thank you. Come on and have a seat. We've got time, I think, for a little bit of discussion. Should we have that now about the imaging? What do you think is the if you could only do one run, which is ridiculous in a case, but which do you think is the most important in the preparation or in the post sort of stenting?
I'm not happy with this question. No, I have to be diplomatic. Honestly, you have the catheter on the table and you need to use it. And that's because you guarantee the success of your procedure, but also long-term result. It's unacceptable to say, I just did it at the end of the procedure, I just did it at the beginning of the procedure, and not peri imperi is very important, especially in the bifurcation and then post-treatment.
Absolutely, and I think, you know, October tells us that systematic imaging is the thing that makes a difference, and if you fail to do that, you may not get the same result. What do you think, Nicolas?
No, I think I agree with Valeria, and both friends are very important. And but maybe there was a question, an answer in the literature from it was not IVUS, but it was OCT, that the MLD Max initiative reporting that when you use 2 runs, pre and post PCI, the pre-PCI runs will modify the operator strategy in more than 70% of the case, and then 30% of the case are more related to optimization after post PCI. So well, maybe that you got much more information from the pre, but the post is also mandatory.
And you showed cases there that had they used imaging maybe the first time, the complication wouldn't have occurred. So it's pretty obvious we need to do it to avoid complications.
I agree.
Nicolas, should we take your talk and then we can maybe open up a sort of an extra discussion, unless there's anything from the audience. Has anyone got a question? No. Well, important to keep the time.
Good afternoon. Thank you for the EBC for the invitation, and thank you for Boston Scientific for the support. Let's start with a case from our cath lab. It was kind of complex true bifurcation from distal left main proxial AD and prox circumflex in a 70-year-old woman with an anterior non-STMI. She has diabetes, she has hypertension, she's obese, and previous cancer with surgery and chassis radiation, and this patient was turned out for surgery. So we had to think about the best way to treat her by PCI and how to tackle this quite complex calcified lesion. The good part is the good point is that the right coronary artery is okay. Otherwise, the rest is a mess. And so, of course, when you want to treat this patient, you have to think about what you can obtain as a result, also the potential PCI complications. So I think it's very important just to take some time in the cath lab to go over the angio and to discuss with colleagues and senior colleagues to think about what could happen in this patient. First is it's very calcified. We have a very highly angulated circumflex, and so we can expect that there will be some stent crossing issues in the circumflex. Second, we have a huge chunk of calcium once again in the distal left main in the prox circumflex, and that is a classical risk factor for an incomplete expansion of the device. Moreover, it's a kind of tapered left main. We can expect that the proximal part of the left main will be larger than the distal part of the left main. So there's also risk for a stretch malapposition if the size is not, if the stent is not correctly sized or the pot is not correctly performed. Of course, if you go for a two-stent strategy, there might be a risk of lack of circumflex coverage according to the technique you're going to choose. And at last but not least, and it was shown nicely by Valeria, we still have a risk of stent longitudinal deformation on the very ostial part of the left main. So each of these arrows indicates a potential complication, and at the end we have a lot of arrows on the angio. So what can we do to avoid that? We have to make a careful procedure planning. Stent crossing failure and incomplete expansion are mostly related to the calcium burden in these lesions, so an adequate lesion preparation has to be performed. And incomplete expansion, severe stretch malapposition, lack of circumflex coverage, and a risk of stent longitudinal deformation can be also avoided by the use of an adequate PCI technique. And at last but not least, you need to check your results and potentially optimize with the help of the support of intracoronary imaging. So what about adequate lesion preparation in bifurcation, and especially in this case? We have probably two main techniques in the cath lab right now. The first one is rotational apherectomy. The second one is IVL. Rotational apherectomy obviously is probably more indicated in this case because it's very tight and there are a lot of concerns about the ability of IVL balloon to cross. So, but the question is how to perform this apherectomy. Should we go for unprotected rotational apherectomy or to protected? Shall we go for apherectomy in both branches or only in the main branches? In the main branch, actually, rotational apherectomy is feasible in bifurcation. You're aware of that. You don't. You can only wire the main vessel and go for the apherectomy from main vessel to main branch, and treat as you will do in after the apherectomy is performed. You can treat as you will do in non-calcified lesion. In this case, we went for culotte. Maybe in the future we will go for DCB. I was very interested by all the talks this afternoon. But in this case, I went for the two-stent technique. So it's this Japanese publication reported that the rotational apherectomy in very calcified lesion is still very interesting and has to be done because it will probably avoid some side branch occlusion and improve the prognosis of the patient. And so it has to be done when you suspect a very calcified lesion and when you want to get rid of that and do an adequate plaque preparation. In addition, this Chinese series was a retrospective analysis of 292 patients with severely calcified bifurcation, and they observed that once again you can do side branch and main vessel rotational apherectomy. That will be efficient. There is a higher risk of side branch perforation. That's something we have to be aware, and a higher risk of acute contrast-induced nephropathy. But otherwise, the technique is rather feasible and efficient. The alternative will go for a protected apherectomy, which means to go for rotational apherectomy through a guiding catheter extension that was nicely reported in this Italian case report. So if you go for that, that means that you need a 7 French guiding catheter and the use of a very small burr, 1.25 burr. Otherwise, you're going to be blocked, but it could be very efficient if you are really concerned about the potential loss of the side branch after the rotational apherectomy. In case you want to go for IVL in unprotected left main, we presented that last year at EBC, but it's feasible. The results are comparable to non-left main lesions, and you can see that there was no, in this series, French series, there was no more adverse events at 30 days, and the midterm clinical outcome at 12 months were comparable between groups. So once we prepared, now we have to move to an adequate PCI technique. To prevent the malapposition, probably the most important point is to properly size your vessel, and that's where intracoronary imaging is very efficient. So that's what I told Peter, that the pre-PCI gives you a lot of information and it could not be neglected. Once your vessel is properly sized, you have to apply an adequate pot and kissing technique if you want to go for kissing. And it also involves a good knowledge of the different devices over expansion properties to get the best results. And so I think it's very important to get this kind of a table in the cath lab where you can you got all the maximal expanded diameter of the different devices according to the baseline diameter, and that will help you not to get confused and to choose the most appropriate stent in case of complicated lesion. What about the stenting strategy? Shall we go for 1 stent, 2 stent, DCB use? There were already a lot of debates this afternoon. There will be more tomorrow, so I won't go, for the sake of time, go too much in that. This is a kind of algorithm that I use. It's very complicated. I try just to summarize what all I learned from the EBC. And anyway, at one point, in the case of this patient, we went for a two-stent strategy because the definition criteria were met, and we went also for an aggressive preparation. For the prevention of LSD, I think that 2 points are very important. The first one is to choose an adequate stent platform and to get a good technique. I personally like to use the Megatron in this kind of lesions because of the presence of the 4 connectors on the proximal segments that increase the resistance to compression. But they are of a good stent with good overexpansion capacities. What I think is very important to prevent LSD is consider floating wire, or now we can go for floating balloon technique. This technique was reported this year by a French group led by Frank Dean, and you see it just basically using a floating wire just to prevent the intubation of the guiding catheter into the ostium, but you will put a small balloon that you're gonna inflate during the inflation of the stent and the part in the left main, and that will help first to correctly delineate the ostium, and second to prevent once again the intubation and the collision of the guiding catheter with the stent. I told you in this kind of complex left main lesion, we need to guide our procedure with IVUS, and we have to control the results with the IVUS. Last year we got a very nice Korean publication reporting the optimal minimal stent area within each left main segment for the two-stent strategy. And this month in Euro intervention, the new cutoff have been proposed for the one stent left main to LAD crossover, and you see that basically it's not exactly the same, but they're quite alike. So, what did we do in our patient? We went for rotablation, rotational atherectomy preparation from left main to LAD and from left main to first marginal branch. DKK strategy was applied with Megatron stents. We used the floating balloon technique, and we controlled the IVUS. We controlled the result with the IVUS, and we got this final result, which was, I think, okay. And the patient got no further clinical adverse events during the follow-up. So, in conclusion, well, if you expect the worst, you will never be disappointed. I thought it was from Monty Python, but actually it was not. So I thought it was British, but it was an American quote. However, even if you expect the worst, if you can anticipate, you are also able to prevent the troubles. So what does it mean? It means that you have to correctly analyze the initial angio and carefully plan your procedure. I think the modern tools and techniques are required to get the best result, and in this perspective, a continuous education is very helpful to be aware of all the new things and new approaches, and so it's extremely important. We have to be very rigorous in the execution of our plan. And at last but not least, I already told you, but it's a teamwork, and the discussion with colleagues are crucial to success. Thank you very much for your attention.
Thank you. That was a very thoughtful presentation and a really lovely case with lots of interaction. We could talk about the case for a long time. But I'm just going to move, because in the interest, we haven't got that long, but I just want to sort of pin you both down, perhaps, just to sort of comment, on left main bifurcation. It's a complex procedure, and you've both shown that it's complex. Do you think we should be restricting it to certain operators in the unit who specialize in this technology and techniques so that we don't have everyone doing it? Because if you are a low volume operator, we know from the data, the outcome isn't as good.
Challenging question. I mean, we know data that, of course, the volume is related to also the outcomes, and we know that, for left main is particularly valid. On the other hand, you might encounter this left main lesion in all settings. So you might have a STEMI and you have to deal with it. So I think training, education, now we have so many tools with which we can use to train the young colleagues that I think we should be all able to treat bifurcation. And of course, if the procedure is particularly complex, calcified, maybe you can think about mechanical support devices, and that's something you can plan upfront, but you need to be able to deal with this lesion.
Yeah, I agree with you. I mean, at least the quite simple left main has to be done by all operators, and maybe the more complex cases might be at least done by 2 operators, one very senior and one more junior.
So you don't agree with our UK guideline that says you should do 15 a year?
Is it 15?
15 a year.
I mean, yeah, I remember that there were some European guidelines, so no British, but it was 25.
Yeah.
Wow.
Yeah. But often it's not the younger colleagues; it's often the older colleagues. We're all getting old. I'm pretty old, but is they're not the people who want to use the Imogens, particularly. I find in our centre.
Then we need to push for training, you know, I mean, or even senior colleagues, you know, you need to train, to push and find a new way, new angle to involve them also in this training, which absolutely will make their procedure easier and also the patient prognosis absolutely better. So I think there's a way to involve also in the understanding and training intravascular imaging.
Agree, and I think this meeting itself is one of the incredible things that's happened over the last 20 years to actually allow these information to be disseminated to other people who don't go to the meeting. Because I think EBC has done for bifurcations what perhaps other areas of lesion morphology might be quite. CTO is similar as well. So it's an interesting kind of concept.
Yeah, I agree. What else?
Has anyone in the audience got any comments? Hands up in the audience who've looked at the Left Main Academy online and have used some of the resources from Boston Scientific. Anyone in the room? Yeah, there's a few. But I mean, it's a free resource, isn't it? And I'm sure the Boston team can give you a bit more information. But I did that QR code that I had up. You can click on it, and there's tons of information. The videos are really, really cool on the bench. Really good. Any other comments, guys?
No.
Almost a question.
I think it's done. So I think if we're done,
I think we're done. I think we're bang on time. 6:30. I want to thank both of you.
which is incredible for an EBC session.
It's amazing. Thank you both. Fantastic speakers. Thanks for the audience. Brilliant. See you later.